Yes, I do have a question about compliance, but just before I ask my question, I'd also like to make an observation.
Yeah.
You mentioned, Caroline, on hand-foot syndrome, that utterly smooth was something that could be used. And for your own information, in case you didn't know, the very first patient that was using utterly smooth was actually a renal patient at Swansea, who was a farmer in 2000,
Yes, yes.
in 2006, 2007, and he had a reaction to sunitinib, rashes on his hands and his feet, and he himself chose to use utterly smooth. And utterly smooth is available from a website, and I'm not joking, it's www.notjustforcows.com. It's not 100% effective, but both the manufacturers of regorafenib, Bayer, and sunitinib, Pfizer, do provide starter packs. This is a regorafenib starter pack. There's a few of them out there. You can help yourselves. And inside is some utterly smooth.
Yeah.
My question about compliance is really quite straightforward. On your slide, Karis, you showed that on that trial, 25% of adjuvant patients on imatinib were not complying, had ceased treatment.
Yes.
This is a universal thing across all the TKIs. In your medical practice, what do you do, or what do you say to patients with regards to compliance?
I think the important thing is, I think within the trials, because it was obviously a trial, patients who maybe have been allocated 3 years of treatment, they knew they were in a trial, so they didn't know whether or not that was 3 years was necessary. So I think maybe now that we do know 3 years is better, when we see patients at the beginning, that the important thing is to explain how important that 3 years of treatment is and why it's important, and that we know that it improves survival. So I think sitting down, spending time and having that conversation up front about the importance of taking it and why we want, the patient to take it is probably the crux of it. And the next thing then is actually keeping it particularly in the first few months of treatment when patients new to the treatment, is making sure that we see them regularly and act on any potential side effects they get. And I think having, absolutely fantastic working with Caroline, she provides a brilliant service, but basically having the opportunity for patients to be able to ring up and speak to Caroline when they develop symptoms, so they don't have to wait for the next appointment or whatever else, and so we can give them practical advice. And I think that that's probably the best way of trying to, we do know that people get side effects, but trying to manage it early and be proactive about it. Hopefully, I don't think we've looked at our compliance, but we might need to. We can get the compliance to be better than that.
I would say that I can't recall anybody who has said, I'm not going to take this anymore. We have had to do manipulations around the dose, and patients will occasionally say, oh, I didn't take it for a couple of days because, or whatever, and then they're kind of back on track. But we haven't really found people who have said, no, I'm not going to continue with this drug.
Okay.
Not sure if it's exactly a question or an observation.
Okay.
This whole area of when you talk about side effects from a drug leaves me a bit worried, because two issues. First of all, if I were to list all my side effects, and I'm on imatinib, the list technically would be quite long, but that would be extremely deceptive, because virtually every one of them is, in my case, very mild and infrequent.
Yes.
So in general terms, I say I have minimal side effects.
Yes, but
it's also a long list.
Yeah.
And so I really struggle when Tori has asked us earlier to list our side effects on the board outside. I don't know what I'm going to write down.
No, it's difficult.
My other question is similar. Also, I don't know what to identify, because for me it's difficult to distinguish between side effects of a drug and of the surgery.
Yes.
One of the side effects you mentioned for imatinib is issues with acid reflux. I had none of that originally until I had surgery.
Absolutely.
And in fact, my surgery took out my entire stomach. So it's not stomach issues.
No.
It's coming from somewhere else, and it's really nasty when it strikes. Again, infrequently, but it probably for me is the biggest thing I'm worried about. Infrequently, but that's not a drug side effect.
No.
So I really don't know how to respond to side effects.
It's difficult, and interestingly, I didn't say it earlier, but there was, within the other trial that was done quite early on, where basically it was a comparison of imatinib with placebo in the adjuvant setting. I think it was figure was something like 68% of people in the placebo arm, so either they weren't receiving any drug, had side effects. So basically, if you ask people, they're going to say, yeah, well, I am quite tired, but it's not the drug, it's just because of they've had a bad day or whatever, or because they've had, major surgery. So it isn't that easy. It's actually totally true that you can't always tease out what is causing what. So it's more management of symptoms, really, isn't it? And I totally agree with that.
And I think I was going to say, that a lot of the symptoms are multifactorial. There will be different causes for different people. And going through surgery, going through a diagnosis of having a cancer, embarking on treatment, which may or may not be lifelong, all of those things will impact on things like fatigue, your well-being, and those kind of things. And that can impact on, that can give you all sorts of side effects, if you like, or symptoms that may just be life, as it were, maybe adjustment to the diagnosis and surgery.
I think it's probably worth collecting all of the information, though, as you say, your list of side effects. I'm sure that it would be worth sharing them on the boards, just because these are symptoms that you have, and you might then find that everyone else has got them as well. Sorry.
Is that working? Yeah.
Yes.
I found after my first surgery, I had huge numbers of side effects. I wasn't taking imatinib, it wasn't available then, but the side effects from the surgery were enormous.
Yes.
I mean, to the point where I was sort of dialing 111 in the small hours because of the pain. And the amazing thing was, when I had to have more surgery for a liver resection, the surgeon said what a mess my inside was after the gastric surgery. And once I'd recovered from the liver resection, I felt better than I had for years, because he'd sorted out all the adhesions and the various other messes that the original surgery had caused.
Yeah.
And I don't think the surgeons always acknowledge the full effect of what they're doing is going to be.
Yeah. I mean, these are not, if you a total gastrectomy or a partial, gastrectomy is a major operation, and we see, a lot of patients who've not got GISTs who've had that type of surgery, and in terms of quality of life, it can often take up to a year or so to recover, and even then, it's with modification in diet and that sort of thing long term. So absolutely, major surgery. These operations are not small operations for the vast majority. So it is very difficult, I think, for the same reason, to pick out what's causing which, basically.
And we have another patient with a debilitating chronic illness, and it took quite a long time to unpick what were the side effects from her medication for that, and what were the side effects from the medication that we were giving her. So that, it can just take quite a lot of careful questioning and looking and trial and error, and to find out those things.
Just as a matter of interest, can we have a show of hands of the patients here, if you want to, that have a similar arrangement to this in their local hospital? Yeah. So, in other words, somewhere that they can go that will help them with pain management and with symptom management. Yeah. Yeah. Okay. Because I think it's an essential part of the whole process.
Yeah, and I think one of the things I didn't say about the nurse-led clinic is it's an opportunity to build up some expertise, to see what happens, to see what works, to get a kind of better understanding of the severity and what we can do about it.
Yeah, because one of the salient points you mentioned was you don't want people that are on these drugs to feel that it's taking over their whole lives.
Yes.
And
Yes.
it would be better for them to have a break rather than go through something that is going to be worse for them.
Yeah.
So.
And I think we are fortunate in that we are able to offer a very flexible approach. So There's a patient that I see very early in the morning so that he can get on to work straight afterwards. There's another patient who doesn't like travelling to Velindre for other reasons, and I have some complicated bespoke service involving the Gwent Hospital, which I'm waiting for it to backfire one day, but so far works all right. So we are fortunate that we're able to work in kind of a
Targeted
flexible
healthcare,
way.
brilliant. Yeah. Any other questions?
Yes, I'd like to. Thank you. I was only diagnosed in June, and I've got, so I don't know really much about the sort of technical vocabulary that you're all using. I've got a rectal cyst, and the mutation is in exon 13. Because I've just had a prostate biopsy as well. I'm waiting for the results. The surgeon said, well, he wouldn't do anything until probably New Year. So I'm trying Gleevec for 2 or 3 months to try and reduce it.
Mm-hmm.
But having looked on the internet, that's only effective in about 20% of cases with exon 13 mutation. So who would decide, you ought to try sunitinib or the other one, Regara, whatever it is. Who would decide whether to use that and whether it might be effective? Would it be effective? So when do you sort of go on to that stage of the next?
I think usually in this type of situation, obviously we don't know all full details, but what I think is important is that for you, because it sounds like there's a lower chance of imatinib potentially being effective, is that you have a quite an early assessment of that. And depending on what your local oncologist has access to, that would either be a CT scan quite early to make sure that it is working, or sometimes people use a PET scan in that situation, because you can quite quickly see whether or not there's been effective.
Yeah, I've got a PET scan booked for November, so after
fantastic.
the first 2 months.
Yes, and I think that would be really important, because that will, because a PET scan will basically show activity in tumours, and usually in GIST it's really helpful because they light up. And if the imatinib is working, you would expect to see, pretty much a turning off of that activity. So PET scans can be really good in that situation to sort of say, is this actually working?
So if it didn't work, are they likely to say, well, it might be worth trying sunitinib or one of the others, or would they not work?
I think they'd want to know whether or not it was operable, basically, because I think it sounds like you're having it as potentially a treatment before surgery.
Yes.
So I think if they felt that imatinib hasn't worked, the more likely thing I would expect is that they would look at whether or not it was possible to operate, I suspect. That's what I think is likely anyway.
And one of the other important things is ensure you're being seen by a specialist GIST doctor or oncologist. We can talk later.